Good afternoon, everyone. My name is Bianca Santamaria, and I work with the University of Arizona Center for Rural Health. Welcome to the webinar series. While we are having people joining us, we would like to take a minute to express our gratitude to Guild Health for partnering with us to provide this exciting webinar. Next slide. I just want to make a note that as the audience, you will be muted for this webinar, but we do encourage you to enter questions into the Q&A box. After the webinar, you will also be receiving a follow-up email with the survey link to the recorded presentation webinar. We would appreciate you taking a moment to complete the survey, as it really helps to have your feedback. And again, at the end of the presentation, there will be a portion of time for a question and answer. Next slide. Before we get started, we would like to take a moment for the University of Arizona land acknowledgement. We respectfully acknowledge the university is on the land and territories of Indigenous people. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education, offerings, partnerships, and community service. Next slide. So today we are very excited to hear from Jason Gillette, CEO of Guild Health Group, and Mark Martz, founder of the CEO and of the Martz and Associates. And they'll be talking about integrating the 2022 clinical practice guidelines for prescribing opioids in rural healthcare settings. I want to tell you a little bit about each speaker. So Jason is the CEO of Guild Health, a public health firm committed to inspiring safe and healthy communities through emergency response planning and research and evaluation services. Jason's path to public health formed various experience and efforts over the past 20 years. Jason earned his bachelor's degree in global health from Arizona State University. Jason quickly jumped into the public health workforce, and Jason has served as a director of school health for the Arizona Department of Education, as well as office chief for the tobacco prevention program at the Arizona Department of Health. Now I'm going to tell you a little bit about Mark. Mark is the founder and CEO of Martz and Associates. Before launching Mark and Associates, Mark was executive director of Axiom Community of Recovery. He has served as a founding director of the Arizona Center for Tobacco Cessation at the University of Arizona, following 5 years of service at the Arizona Department of Health and Human Services as a policy consultant, program manager, and chief for tobacco prevention and cessation. Mark received his master's public administration from Wichita State University and a doctorate in public administration and policy from the Arizona State University. And again, thank you everyone for being here. I'm going to turn it over to Jason.
Thank you, Bianca. I appreciate it so much. Good afternoon, everyone. Thank you for being here today. We are glad to jump into this topic of integrating the 2022 clinical practice guideline for prescribing opioids in rural healthcare settings. This conversation will be discussing and understanding what it looks like to integrate the guideline, and also what we can do to improve our process in the rural communities. So thank you so much for being here. So our learning objectives this afternoon will run the gamut, but this is what we're going to focus on. We are looking at becoming familiar with the 2022 clinical practice guideline for prescribing opioids. We're also going to learn how prescribers and public health professionals can utilize the guideline in the rural healthcare setting. We're also going to learn ways that practitioners can integrate the guideline into their EHR practice, the policies, and workflows. And so just as a disclaimer, we do not have any conflicts of interest or any financial interest to disclose. And more importantly, we are not licensed medical professionals. The information we're presenting here is from a public health perspective. We are for the education only and not to be used to diagnose or treat medical conditions. So today we'll cover a brief history of the guideline. We'll look at how we'll present on the data from the national and Arizona context. We're also going to be looking at how we're going to utilize the guideline within a rural setting. We'll also discuss integrating the guideline within the EHR workflow, whether it's the CSPMP, and hopefully we'll have a chance to have an open discussion around what that looks like and answer some questions along the way. So our perspective, as we said in the disclaimer, Mark and I are not clinical professionals, and so we are public health professionals. And so the diagram that you see on your right is the 10 Essentials Public Health Wheel that looks at our lens, right? This is the lens in which we look through the entire scope of practice, implementation, and evaluation. And so we look at this wheel as a way in which we look and distill information so that we can better understand how it builds communities, improves access to care, and improves quality of life for those in the community. And so our goal is to find that golden thread between all of the things that we do as public health professionals and how that will improve the access to care for those struggling with opioid use or looking for ways to get better access to care for those in need. And so mindful thinking and planning is what we focus on. So the 10 tenets of the public health circle allow us to then filter all this information and give useful and evaluative feedback. And then lastly, we want to operationalize into action and evolve and sustain over time. And that's exactly what public health is key for, is looking at how do we build programs that will last so our communities can have access to better care and quality of life. And so our guidelines, as you see in this image, focus on assessing and monitoring the population, understanding what the issues are and addressing those health and hazard root causes, communicating effectively and making sure that our partners are educated so they can communicate effectively, strengthening and supporting communities, creating champions and policies that make laws easier for us to implement these strategies. And along the wheel, we go to utilizing and organizing regulatory actions all the way to building and maintaining strong organizational infrastructure for public health. And that is the lens in which we'll be looking at all of the information before you. So I'm going to turn it over to Mark, who will go through a history of the guideline, a cursory look.
Thank you, Jason. Thank you for that wonderful explanation of kind of how we're approaching our interpretation of the guideline and the extent to which we can integrate that within a rural healthcare setting. Next slide, please. So putting this into context, and many of you are probably very likely aware of the evolution of the opioid epidemic at a national level, but we wanted to make sure that we illustrated that as we begin talking more specifically about the guideline itself. And so, starting around the early 2000s, we started to see this slow uptick of opioid overdose deaths, really hitting a peak around 2015, trending upwards 2016, and then close to where we are today, where any opioid overdose deaths per 100,000 have increased exponentially, as have opioid overdose deaths tied to synthetic opioids, where we're also seeing a downturn or a leveling off of overdose deaths related to commonly prescribed opioids and overdose deaths connected to heroin use. Next slide, please. So placing this opioid epidemic and the evolution within an Arizona context, we see a very similar trend line, which is not unexpected, sadly, but it also kind of just reinforces what's happening around the nation is hitting home here within Arizona and across all the other 49 states in very similar ways. So it's not and that's hence the definition of an epidemic, right? It's not just happening in one place or in a region, it's happening nationwide. So we just wanted to illustrate that national and Arizona state level context before we dove into the guidelines themselves. Next slide, please. So thinking back to those figures, right, the peak and overdose deaths really started occurring around 2014, 2015. So with that in mind, national thought leaders, subject matter experts, thought it would be helpful to create a guideline for prescribing opioids for chronic pain. And this was released in a part of an MMWR, March 18, 2016. And what it did was offer 12 distinct recommendations that were categorized in three specific ways and supported with a category A or category B recommendation for how they would be implemented in practice, and the extent to which each of the recommendations was supported by the evidence base. So this was evidence collected in peer-reviewed literature, interviews with subject matter experts, and the like. And you can actually click on and review, and I highly encourage everyone to read through this using the link on the slide. Next slide, please. One of the real tangible assets that came out of the 2016 guideline was this checklist. And I thought it was worth spending a little bit of time sharing with you today. And we'll talk more about it later in the presentation. But this was something that was really practical and useful, right? Because if anyone has actually read the guideline itself, either the 2016 or the 2022 version, it is very laborious reading. Just very simply stated, right? It's very deep, it's rich, there's a ton of content in there, as it should be. This is a very important topic that needs that level of attention, right? But there's also practitioners and public health professionals that need to be able to use that information in relevant and meaningful ways that are practical. And so I thought highlighting and showcasing this checklist was something that made a lot of sense to me, again, through that 10 essential public health wheel, right? It's translating the information, it's educating the community on how we can affect change in general, but also in a rural context or unique specific contexts. And we'll talk more about this later on in the presentation, but I thought it was worth highlighting here at the front. Next slide, please. So as you can imagine, the world between 2014, 2015, and 2020, 2021-ish changed, right? Obviously, COVID-19 was alive and well. Prescribing patterns, opioid overdoses, changes in substances that were being found, the rise and increase of fentanyl was starting to really ramp up. And in response to that, many of the same subject matter experts, academicians, practitioners came back together to review the 26 guideline and make a concerted effort to kind of unpack it and revise it and put it back together in ways that reflected the current landscape of what was happening, so that the guideline was more current, more responsive, and more useful to anyone that would use it in their practice or in their research or both, right? A couple of the updates from the 2016 guideline that appeared in the 2022 version that I'm highlighting here is that it was really broadened to providers that were prescribing for outpatients 18 and older, in addition to those acute care emergency department settings. So that was a change. And then I thought a very noteworthy change was distinguishing prescribing for acute, subacute, and chronic pain, as opposed to just chronic pain in general, right? So they were really incorporating the nuance to refine the guideline in ways that made sense for the different interactions that a clinician may have with an individual patient, even though that's very challenging to do. But they did their best, and I thought it was worthy of noting in today's presentation. Next slide, please. So here is just a brief highlight of some of the similarities I found between the two versions and some of the differences. Um, as with any guideline that's published at this level, a lot of intentional thought went into the methods that were used, and they stuck to those methods for the most part, which is important, right? Because that provides consistency and methodology, so that the logic, the rationale, where these recommendations were coming from and why they were put together and supported with the literature was very consistent between the versions, even though there were some nuances and changes that I mentioned earlier, and some changes with how they were categorized, and the level of evidence that was used to support the recommendations that were offered. And again, there's hyperlinks here so that you can review this all in detail following today's presentation. Next slide, please. So we've talked about kind of the genesis, the need for the evolution of the guideline from 2016 to 2022. We thought it was worthwhile at least presenting at a high level each of the guidelines, or excuse me, the recommendations that were included in the guideline, so that for folks that might want to revisit this and didn't want to necessarily go into the MMWR and read through all of it, you would at least be able to see each of the each of the recommendations under their unique classifications, and reference them accordingly. So I'll start out with the first couple, and then I'll turn it over to Jason for the remaining few. So again, they're categorized into three kind of subcategories. The first category is determining whether or not to initiate opioids for pain. So this covers recommendations 1 and 2. We've highlighted what we thought was kind of the off the page verbiage that represents the recommendations. So here for number 1, non-opioid therapies are at least as effective as opioids. For the second, non-opioid therapies are preferred for subacute and chronic pain. And again, if you open up and you read through the MMWR, the full guideline, it goes into great lengths to explaining how they got to where they landed with regard to each of the individual recommendations and the categorization of each one and the evidence type that they're supporting each recommendation with. Next slide, please. The next category that serves as the umbrella for recommendations 3, 4, and 5 is selecting opioids and determining opioid dosages. And again, this is more from the clinician's, prescriber's perspective, but it really does provide that guidance on being mindful of what you're prescribing, what are you prescribing it for, if you have an opioid naive patient, etc. Again, not to replace or supplant any training or personal relationship a clinician has with a provider, but to provide that guideline, that guidance, that reference point, the bookend, right, to help make those more informed decisions over time. Next slide. And I believe, Jason, you're going to take over this one here.
Yes, and so deciding the duration of the initial opioid prescription, conducting the follow-up recommendation. So these guidelines, this recommendation rather, was focusing on looking at the acute pain for clinicians and how they should prescribe no greater than quantity needed for the expected duration of pain, severe enough to require opiates. And so understanding, and to Mark's point, making sure that we're cognizant of that client and patient, that clinician and patient relationship is where that judgment really takes place, and there is no place outside of that we can exercise. But we want to make sure that we understand that these recommendations allow us to kind of see the world from our patient's perspective. Number 7 says that clinicians should evaluate benefits and risks with patients within 1 to 4 weeks of starting opioid therapy. And so again, that check-in and building that relationship with our patients, making sure that we understand where they're at and what dosages they're on, how they're responding to that. The next one, these are assessing the risk and addressing potential harms of opioid use. We highlighted again the most salient points in the recommendations. Number 8 saying before starting the periodically during continuation of opioid therapy, clinicians should evaluate the risk of opioid-related harms to discuss that risk with their patients, right? And so understanding that this is about the relationship between patient and doctor, and understanding where the needs are. Number 9, also stipulating that clinicians should review the patient's history for controlled substance prescriptions using state-prescribed drug monitoring program, which is the PDMP, and we'll talk a little bit more about that at the end of the presentation. These other recommendations here, 10, 11, and 12, that finish us up. The 10th says that the clinician should consider the benefits and risks of toxicology testing. 11 says that the clinician should use particular caution with prescribing opioid pain medication and benzodiazepines concurrently. And lastly, the 12 says clinicians should offer a range of treatment with evidence-based medications to treat patients with opioid disorder. And Mark mentioned earlier in the MMR that released in 2016 that they had these categories and they had these evidence types. And so I highlighted at the bottom here the category A, evidence type 1. What this suggests is that category A and B are specific to different populations. Category A is for all general populations, for everybody. This applies to everyone. Whereas category B suggests this applies to clinicians, and so your specialties. Your evidence as well is different and categorized as well by saying evidence 1 through 4. 1 is the most highest of evidence peer-reviewed information versus 4 is on the other side of that. And so when we see these recommendations and categories, we can see that this number 12 is something that's recommended for everyone, and this come with the highest level of academic rigor and research and support evidence for it. And so when we see these recommendations and these evidence types, we can better see how they fall into the importance of our practice, if that's what, or the level of research and information and evidence that supports these guidelines and these recommendations. And so when we talk about understanding what these recommendations are, we also have to put them into the rural context. And so working in perspective is understanding how we see this information and how do we translate that into a rural community where we have different variations and different opportunities. And so we're going to dive into a little bit briefly into what does it mean to be defined as rural, and how does that change when we talk about implementing projects and strategies in rural communities? So understanding the importance of what it means to be rural is what we'll dive there, understanding the norms, beliefs, values, and traditions. And this is important. Working in rural communities, you'll see oftentimes the norms, values, and beliefs and traditions are on the front of these programs, on the front of these implementation strategies. In rural communities, you'll see a lot of times that these values and their values are preeminent. They matter. And so how do we make sure that we're making their values, their norms, and their beliefs as important in the implementation of the strategies that we're looking at? Trust and relationship is also critically important. We want to make sure that trust is, I think all relationships build and are built at the speed of trust. And so how are we building in that trust in our programs? Is that communication? Is it follow-up? Is it spending more time with our patients or with our community to let them know that we're there and where we mean that we're there? That is critical in implementing effective programs in rural settings, because we have what we call just community awareness of what the programs are. And we'll see sometimes in rural settings that the programs are there, but the awareness of them or the relationships with the community is missing, and so those programs don't get implemented. Another point is the infrastructure and capacity. We define rural by their infrastructure and capacity, where geographically and population density are two of the subsets that define what it means to be rural. And so when we look at the infrastructure, there aren't 25 different healthcare providers to choose from. There isn't 16 therapists that choose from in these areas. There's not 7 facilities to go to. There's not 7 major hospitals. You're oftentimes looking at one healthcare facility within the geographic area. and maybe a hospital within driving distance. And so we see that infrastructure capacity limit how programs and these strategies can be implemented. And lastly, clinical specialists and access to care, meaning that we just don't have the numbers. And so when we talk about implementing strategies in rural communities, we may have 1 or 2 clinicians that are trying to implement something on a larger geographical base. And we just want to be mindful of that as we're trying to roll these things out. And so when we talk about defining rural, as I mentioned earlier, population density, distance or remoteness, industry or economy, and then cultural, socially, these are the things that pull and define our rural populations. If you've worked in rural communities, you'll know about the population density challenges. You'll see that they're either spread out. We'll see that there's limitations into who's accessing care or who can get to care. Distance and remoteness, again, driving from Gillette County to Phoenix is an hour and some change. And so getting care, if there's not access there, where do we go? Industry and economy and culture and social norms, right? Our cultural norms. What is our Native American partners focusing on, and what are the needs there? What are the community needs at large right there, and how are we addressing those things? And so when we talk about implementing these things in a rural context, it's important for us to know what is there initially and what needs to be implemented. And so our public health wheel shows up again. And it's because this is where we do our public health thing. We assess and monitor, right? And so we talk about where are we at right now? We identify the problem and its capacity, and how are we currently implementing strategies to address it. Where we are currently defines everything else. And then communicating effectively is something we do for both internally for our staff, but then how are we communicating and mobilizing our partners, right? If we're working with nonprofits, and other community organizations, or even with local municipalities, how is that information and communication being shared? How are we making sure that the new guidelines are being handed out to all our care professionals in a way that we can measure understanding, and also see if there's any questions and provide that support. And then lastly, strengthening, supporting, and mobilizing communities and partners. We cannot do this alone. And so when we talk about implementing strategies in a rural context, it is always going to be most effective to do these things in a collaboration, because we just need more capacity. And oftentimes you'll notice that the communities that you need are already established. We just need to plug into them and then make sure the information gets out effectively. And so as we look at the public health wheel, we can see that we are doing the red, the green, all the way up to the blue, making sure that we build a diverse and skilled workforce. And so all of these things allow us to look at our strategies and our implementation in a way that allows us to monitor effectively, evaluate, and then strengthen our programs. And so I'll turn it over to Mark to talk about guideline integration and the steps and approach.
Thank you, Jason. So just kind of recap where we started. So we talked about kind of our perspective. It's kind of our golden thread on how we're approaching this topic, and then the need for the guidelines, the evolution of the guidelines, bringing this into the rural context. And so with all of that in mind, then I think now we've kind of set the table to start talking about integrating the guidelines. And when I first started in kind of doing my research into this topic, my first thought was the technological integration, and that was kind of the one-stop path of integrating the guideline into a practice, a workflow, an EHR. And the more that I was learning and talking with Jason and going over, kind of filtering this through the 10 essential wheel of public health, there are different ways of integrating the guideline into a rural context, including the EHR, and we'll talk about that. But there might be some other ways of integrating the knowledge and educating practitioners and patients and members of the community that include the technology integration via an electronic health record. And one of those might be standardizing that prescribing checklist. I mean, the one that I presented earlier was from 2016. It certainly would need to be refreshed. But if it was something that you could put on the wall of the public health clinic, or in the public library, or in the pockets of the providers and the healthcare professionals that are interacting directly with patients, right? Like everyone is referencing that checklist, right? Familiar with it, so that when you're having those conversations, you're just so much more cued for success in that way. And that would be something that might be the best fit or starting point for a practice or a public health clinic, or another, like an IHS facility in a very rural part of the state, right? Where they might not have an EHR. If they do, they might not have the funding to upgrade their EHR to be ready for an integration with the PMP, for example. So I just wanted to share this thought that integration doesn't necessarily need to start with that high-tech option. You can start with lower touch interventions and programs and supports that I think would definitely add value to the prescribing practices and outcomes that are happening in rural areas. But of course, if the leadership, the decision-making, the funding, the resources are there to integrate the guideline and the 12 recommendations directly into an EHR, the CDC has, and we provide references at the end where you can click on the links and learn all about that process. But there's actually like coding that you can use. There are APIs that and hooks that you can use to kind of pull these data interfaces together to add in the recommendations within a clinical practice workflow, right? So that it's a seamless process. Second to that, though, here in Arizona, the Board of Pharmacy has created a portal for their CSPMP or PMP, where prescribers can access prescribing history data information on individual patients outside of their EHR. Takes a little bit more time, and time means a lot when you're interacting with patients, for sure. But that solution exists currently. So it's not a full integration, it's kind of a partial integration, but it is a possible process. And we just didn't have the time to kind of walk everyone through step by step, but we do present links where you can learn more about that. And Doug Scavarla and his team at the Board of Pharmacy would welcome you with open arms to that conversation on how to get you started using the PMP portal and or fully integrating that into your electronic health record. And there's actual funding for that integration process. So lots of excitement there. Next slide, please. Oh, yeah. And so here's the actual landing page that you will see by clicking on the link that will take you to the Arizona Board of Pharmacy's prescription monitoring program. And if you were to click on that integration icon, it would take you to all the information, the points of contact, the process, a little short video on how it works, and then a link to a form that you would complete to request someone from the Board of Pharmacy to meet with you to kind of discuss where you are, where you need to go, and what steps might be needed to get you ready for that API interface with the state PMP and your unique EHR. Next slide, please. So again, pointing back to that golden thread of the 10 essential services that public health is kind of grounded in, integrating the guideline into the recommendations, into policy, into practice, into education. And Jason and I thought a couple of ways you can do that is anytime you're onboarding new staff, right, that are interacting with patients, or public health staff that are interacting with individuals coming into a clinic. Certainly anyone who's involved in the prescribing process or educating and informing patients on prescribing opioids, include specific educational opportunities and ongoing professional development opportunities for providers and staff so that they're kept current. They even know what the 12 recommendations are. I would venture to guess that there are a significant number of practitioners that might not even be familiar with the 12 recommendations. So even just familiarizing yourself with them and understanding that they exist, and a lot of time and effort and thought went into creating them, and then figuring out how you translate them into your own practice workflows, your clinic workflows, and in your own personal individual decision making. One other aspect there too is, like, again, outreaching community, educating them, harms and dangers, benefits, risks, resources. Many counties, rural health departments, healthcare facilities have web pages, like dedicated space where people can access that information, and that's great. But proactively outreaching and engaging community, getting the pulse on what's going on, understanding, especially in a rural context, what their fears are, what's the stigma around opioids and fentanyl and all of that, to help kind of demystify and make those conversations easier to have should someone need to have that conversation with an individual about managing their subacute or chronic pain, and so on and so forth. And then next slide. And then finally, again, pointing back to what makes a community rural, and dovetailing on what Jason talked about earlier about, the oftentimes lack of staffing or pain management specialist providers in a particular area, or ability to deliver medication assisted treatment, or substance use disorder treatment, inpatient, outpatient, intensive outpatient, working with community partners in rural areas to thoughtfully recruit, support, train, onboard, maintain that skilled and diverse, culturally reflective workforce that can work in concert with one another, to really make the end-to-end connections with regard to prescribing in general, but opioid prescribing more specifically, and how all of that is informed by the guideline and the 12 recommendations, right? And the very unique characteristics of that rural space, because what's going on in northern Apache County and the needs and the challenges there might be vastly different than what's happening in Nogales, right? So again, it's just placing all of this in context, right? And really thoughtfully going through all this nuance to build programs, workforce, policies, workflows, integrations, etc., that best meet the unique needs of the communities in which they're going to be operationalized and supported. And from Jason and I's perspective, filtering all that through that 10 essential public health services wheel, we think is a really good way of doing it. Next slide, please. Okay, well, that's it. So thank you. And now we would welcome questions, discussion, anything that all of the above. And thank you.
Okay, thank you, everyone. We do have a couple of questions. I'll read the first question off. One of the questions is Guild Health Group offering an opioid summit in Flagstaff in 2024 like they did in 2023?
That's a great question. Maybe not this year. We looked at putting something together. We did have a virtual summit in April of this year, and that was because of demand. We had like 70 people that wanted to be a part of it, and we didn't have space for that in Flagstaff. So our goal is to do one again next year, but this year we did a virtual one, and hopefully next year we'll be able to do an in-person one up in northern Arizona, so we can have all of our colleagues and friends come up and really start dissecting this conversation. But I hope you enjoyed the first one, and we're looking forward to doing the next one.
Okay, thank you. We have another question. How do you recommend we collect PMP checks by providers to share this data with our opioid stewardship committee?
That's a good one. That's a good question. Can you run that by me one more time, Bianca? That's a good question.
Okay, so the question is, how do you recommend we collect PMP checks by providers to share this data with our opioid stewardship committee?
I
So,
can take us, or go ahead, Jason.
oh no, I was going to say, Mark, by all means, yeah.
Yeah, so I would defer to Doug Scavarla and his staff at the Board of Pharmacy, because they are living and learning this every day, right? This is what they do day to day. However, I do remember I was writing a grant with the Board of Pharmacy and the U of A, actually. This would have been 2014, 15, to secure federal dollars to build out state PMPs, right? Just for this purpose. And that was one of the questions, right? Like, how do you, and I hope my translation of your question is on target, and if not, forgive me in advance. But one of the questions was, um, uh, uh, do we create a report card? And I remember there's a lot of discussion. We actually created a report card. A report card was created to send out to providers, but some of the pushback was, well, I mean, what's the enforcement of that? And the thinking was, actually, if we frame it in ways that are educational and not pejorative, certainly you want to flag prescribers that, for all intents and purposes, via the data, are clearly overprescribing, right? And there were state guidelines that ADHS put out in 2017, 2018, I believe. And even in statute, and I can't remember the statute reference, but that basically lists how many MMEs you can prescribe within a certain period of time for any given patient in concert with, and that it's, that whole thing. My thinking takes me to, um, if the report card still exists, and I'm not sure that it does, so forgive me there. If there is a way to collect your prescribing patterns for providers within your networks, I would do it in a way that potentially de-identifies the provider, but also does not diminish or take away any prescribing practices that you may deem as not in alignment with state statute and best practice, right? And then use that as an opportunity to educate your prescribers on what the statute is and what clinical best practices are when it comes to prescribing. That's probably how I would approach it, again, through that public health lens of education and outreach and engagement, right? Because, and here's a hypothetical example, and you can't make policy from hypotheticals, but here's just a thought example. Maybe someone's really trying their best to prescribe medications in a way that's helpful to their patients, but perhaps they haven't been trained in, pain prescribing with complex patients. Maybe they're stepping up against the bubble of their knowledge, right? You want them to continue to work in their mission driven, practice area, but do it in a way that is not harming anyone at the same time. So I don't know if that explanation helps or muddies the waters anymore, but for me, it's that approaching it not from a pejorative law enforcement legal ramification perspective, but maybe approaching it through a public health lens of, hey, I'm going to come alongside you and I'm going to meet with you and open up an opportunity for you to share, like, hey, what's going on? How can we help you learn, train, educate, those kinds of things.
And the respondent did say thank you for your answer, so thank you for that, Mark. They also had a question of who is a pharmacist at the state board to contact?
Yeah, so if you go to the Arizona Board of Pharmacy website, and I think we have a link there or a link to the landing page.
Yes.
You can connect with Doug Scavarla. For pharmacists, however, There is the Arizona Board of Pharmacy, and they have a wonderful team of folks there that support the needs of pharmacists specifically. And their use of the PMP, right? So they will absolutely check the PMP on their end and can do that, have that capacity to do that too. We framed this presentation through the lens of like office-based providers and public health professionals. But certainly there is a very specific workflow for pharmacists, and the Arizona Board of Pharmacy that absolutely will support the needs of pharmacists. And I believe they even have trainings and reference resource materials on their website that are unique to prescribing or filling pharmacists.
Okay, any other questions? I know it was mentioned in the chat that if anybody has a question, they can unmute you so you can ask it yourself, or feel free to type it in the question and answer. Okay, if there are no further questions, I think can conclude. Again, thanking Jason and Mark for their amazing presentation. Anything else you want to say, Jason or Mark or anybody?
I just want to say it was a pleasure getting the chance to share this information, and I hope it was useful, and we look forward to the next opportunity. Thank you very much.
Yeah, and I just want to say thank you too. Thank you, Bridget, Bianca, Jen, for inviting us. This was great. I did put a link to the Arizona Board of Pharmacy website in the chat, and then in response to the Q&A specific to that request, so you can go there and connect with Board of Pharmacy folks. So thank you. This was great. Thank you.
Thank you, everyone. I think there's still an attendee online. Oh no, not anymore.
Yes,
Okay.
I just removed her. Sometimes people are a little slow finding. That was great. That was such a
Yes.
rich and thoughtful presentation. I learned a lot. It's not my area of expertise, so I learned quite a bit.
Very
and
well done. I agree.
yeah, and I know there were only about 6, 7 in person, but we have noticed in recent months a trend of people registering a portion, like a subset attending in person, and then we get a lot of hits afterwards on the recording. So I don't know how you all feel, but I think this would be a good one to promote the recording in our newsletter coming up next month, because it's really, really practical and useful information. So if you all are okay with that, I think we should definitely promote the recording as something, as a good reference.
I love it. Yes. Yeah.
Absolutely. Yeah.
That was,
Okay,
I had
cool.
fun. That was so much fun.
Cool.
Yeah, I agree. It was really well done. Really, I mean, Mark, when you said it was like, diving into the guideline is just like overwhelming. And that's so true, right? But you guys made it very concrete and very easy to follow. And Jason, I just loved that you talked about opioid use disorder treatment and talking about specifically the evidence around that one, really highlighting that it's for everyone and it's strong evidence. Again, really grateful for that. So thank you so much. And I learned a lot too. So that's great.
How often are those guidelines updated? Because it seemed like It had been what, like 8 years or longer between the.
Yeah, that's a good question. I don't know how often they're updated, but there was one that came out just June 6th, 2024, that we kind of noted there. And like, it says they're weekly reports, but I know that there's some of them, the guidelines don't come out weekly. I know there's just the MMR has these reports that come out weekly.
Yeah. And those updates are like, that's a national level policy change. Yeah. It's really interesting. Just as an aside, like, with this presidential election coming up, like I just feel like I'm so glad that some guidelines have been updated and are on the books now, because who knows? Who knows, you guys? There's
There's so
there's a little bit of anxiety over just all those, like, career agency folks who may or may not be able to do their work. So I'm so glad that there has been a good guidance issued.
Yes, absolutely. We got something on paper. That's all that's the most thing. That's all we can ask for right now at this point.
Yeah.
And I'd love to see more research. And I know we're developing surveys. We're better trying to understand what's happening here in Arizona. But when I was going into the literature and like spending lots of time trying to find anything about the relationship between integrating and outcomes, it's really hard. It's still kind of
Right.
dropping in, and so, gosh, I just hope, to your point, Jen, that there's continued funding for research to better understand how all this is translating in the real world, and what can be learned and shared across different landscapes and contexts that in ways that make sense, right? Like, and I thought Jason bringing in the public health 10 essential, it's brilliant, right? Like, it's like, okay, so like we can talk about the guideline. I mean, we've all been to those webinars where it's like dry and academic. Here's here's the evidence base, and that's great. That's awesome. That's revolutionary in and of itself, right? You've shifted the thinking in this particular. That's awesome. Now, how do we take that and talk to someone on the Navajo Nation that's like trying to figure out why so many of their folks are, you know what I mean? Like that whole thing. And so.
And I'm glad you said that, Mark. I was going to say I incorporated the wheel just because that's how I see the entire world. I was trained to see the world from that lens. And so it's kind of pigeonholed me to kind of see. I have only one shade of glasses to see the world through, but that model allows me to ask the questions. It allows me to ask the questions of what do I know, what don't I know, and all the way around that model, you get a chance to see. No matter if you're doing a clinical, you're trying to integrate an EHR, you're trying to build a breastfeeding community program. That model allows you to ask, what do you know, what don't you know? You just follow it all the way around, and you at the end you have information that can either build a successful breastfeeding program or an EHR integration method. And so being able to introduce people into how simple that public health model is and what it really does. I told Mark one time, like, public health is like Tupperware, right? No one's bragging about it, but if you really, like, everybody has Tupperware at their house, I guarantee you. And the reason why is because it's utility, right? It makes sense. It allows you to frame and hold things that you would oftentimes go away from. So public health is in that same, it's a model in which you can hold something and preserve it and move it and observe it from a way that you can objectify it. You can say, this is what this is. This is nothing more than just a solution or an answer that needs to be answered in a different way.
Yeah. Yeah, and kudos, Mark, like you got that question at the end and you applied that, you modeled that so well in thinking about, like, well, how do we apply this to, the question of, regulating the prescribing physicians' behaviors. So that was really cool.
Right. Totally.
Yeah.
It was so practical and really talking about, like, let's not be punitive, right? Like, let's just get better. Let's make it better and what are some of the issues. I think again goes right back to that. Really good.
Yeah.
Yay.
Well, Bianca, would you be good with you and I following up about making sure to get this in the newsletter and stuff to make sure eyes get on this presentation?
Yes, I agree. I think it's a really good presentation and wanting to share it with others as well. So
Awesome.
Cool.
All right. I'm gonna jump off. I'm gonna go pick up my kid. But I really, really enjoyed meeting both of you in person today, and thank you so much.
Likewise.
Jen, pleasure.
Thank you, Jen.
Thank you.
Thank
Bye.
you, Bridget. Thank you, Bianca.
thank you.
We'll see you
guys
soon.
soon. Yeah.
Bye, everyone.
Take
Okay,
care.
bye.